so Kevin and I are going to talk about the interviews of international participants. So we recruited 12 humanitarian health workers and 12 policymakers, and many of these policymakers actually had frontline field experience in the past, as is often the case in these organizations. We recruited them through our survey participants, through social media, through our professional networks, and also by asking some participants who else they thought would be really important to speak to in this context. Our participants were a diverse group of expatriates who were interviewed between November 2016 and May 2017. We looked at the transcripts using interpretive descriptive methodology, and we had two main questions in mind, and I'm going to speak to the first question. This is what it was. So what we did is we used the concept of moral experience as an analytic lens to look at the transcripts as we sought to better understand the participants' experiences of their values that they held to be important in the provision of palliative care, and whether these values were either realized or thwarted during the humanitarian context. We found 5 interlinking themes when we asked these questions. And these are those themes. So initially, participants really viewed acting to ease suffering as a duty for all patients, but even more so when they were considering patients at the end of life. One participant explained that acting to ease suffering was central to the DNA of their work. This duty or moral imperative was closely linked to the second theme or dimension of moral experience, which was the duty to uphold the dignity of all patients who were dying. While participants acknowledged the real systemic constraints which existed in trying to provide palliative care, the need to advocate to address these constraints was really clear in that theme of dealing with constraints. Participants felt that the priority of saving lives really needed to be balanced against the need to address upholding dignity and easing suffering, and that was the 4th theme. Finally, the transcripts overwhelmingly conveyed the weight of responsibility that participants felt. And one participant expressed this, and I just want to read the quote. But I don't have a way of keeping them comfortable and letting them die in a warm, comfortable place. And that really haunts me. I kind of think, like, I'm not religious at all. I'm atheist. I don't believe in hell. But I kind of think there's a special place in hell for me.
So this was the second question that or second lens in some ways that we looked at the transcripts through. And in my mind at least, we were kind of drilling down on the systemic constraints and the balancing priorities to sort of ask the question, if palliative care is going to be integrated, what are the obstacles and challenges to doing it? And I think it's important to say that respondents, while they identified many obstacles and challenges, also made suggestions about potential solutions. This is a very busy slide in some respects, but I felt I couldn't leave it out because it was so much work to put together. But I'm going to talk about the 6 major priorities, and maybe I will touch, if Matthew will allow me 30 more seconds, I will touch on the terminology one as well. So, starting with priority setting, quote, how is it possible to ensure palliative care in the absence of basic curative care, unquote. Scarce resources and extreme needs do require sometimes rigorous triage and decisions about resource allocation. The respondents were quick to point out that this was not in all situations or at all times, and that minimal resources are sometimes required to actually deliver palliative care, and it can be done by non-healthcare professionals in many instances. Funding was seen as a possible challenge. Quote, heroes who save lives, that's what's in the imagination of those who give us their money, unquote. Assumptions need to be tested, and impact needs to be, sorry, I'm having a little technical problem. Okay. So these assumptions they felt needed to really be tested. And impact of palliative care, and we need to figure out how to measure it and how to share it back with donors. Expertise and guidance. Guidelines and training, as we've already heard, in palliative care are limited in the humanitarian community, but again, our respondents really felt that this is something that could be relatively easily addressed. It's something we could build together. Pain medication, access to pain medications, especially opiates, is very difficult in many contexts due to legal restrictions and logistical issues. But again, I would say the overwhelming response was that this is an essential medicine, and like any other essential medicine, we have to figure out how to advocate for it and how to make sure it's available. And then the issue of cultural specificity. Quote, how death is managed, how death is social religious construct is very different from what some foreigners might be used to. So again, this is recurring, I guess, in a way, but the idea that local, cultural, spiritual, and social dimensions do have to be taken into account. But this is not, again, something new. It's something that, with a spirit of humility and engagement with local providers and local communities, this can be addressed. Finally, and I think perhaps, well, actually, I'm going to speak briefly about the issue of terminology. Clearly, the notion of palliative care, what is palliative care? Is this end-of-life care? Is it supportive care? I think, again, I would say the pragmatic response, and maybe this is a reflection of humanitarian culture, the pragmatic response is we need to figure out what we're talking about. We can call it different things if we need to, but what's important is that care is actually available. Then finally, maybe we'll speak to the ethos of humanitarian work. Quote, they let them die without anything, because they had never considered palliative care in situations of crisis. The feeling was that the primacy of life-saving can sometimes overwhelm the humanitarian values of alleviating suffering and promoting dignity. But that these values were very important values for some of our most vulnerable recipients. But there were two very critical caveats that humanitarian workers, I think, highlighted for us. Life-saving is still the primary objective of the work that we do, and it remains essential. And palliative care can never become a justification for not providing the best care possible. So there was some concern, certainly raised, that that was something that we might inadvertently create. And I think that's all I have to say.